I'm Dr. Sarah Hurvitz, Professor of Medicine and Head of the Breast Cancer Clinical Trials Program at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. When a patient's disease progresses on first-line aromatase inhibitor and CDK4/6 inhibitor, the standard of care is to evaluate the tumor, usually using a circulating tumor DNA assay to detect a mutation in PI3 kinase called PIK3CA. If that mutation is present, then the next treatment, in my opinion, would be to use fulvestrant combined with alpelisib. And this is based on the SOLAR-1 study that showed in patients whose tumors harbor a PIK3CA mutation, the addition of alpelisib to fulvestrant significantly improves progression-free survival. The overall survival is not significantly different, but the PFS difference is on the order of 5 or 6 months, which I think is clinically meaningful. One thing to note about alpelisib is that it does have a number of side effects that require very careful monitoring and patient education, including grade 3 hyperglycemia, rash. I use upfront prophylaxis with an antihistamine on day 1 to try to prevent, because you can see grade 3 rashes, as well as diarrhea. So there is a learning curve to the use of this agent. In the 60% or so of patients whose tumors don't harbor a PIK3CA mutation, my choice is everolimus combined with either fulvestrant or exemestane. The use of everolimus plus exemestane was evaluated in the BOLERO-2 study and demonstrated around a 6-month improvement in PFS. Again, no difference in overall survival, but a clinically meaningful improvement. The tolerability of that regimen is greatly improved with the use of prophylactic steroid mouthwash to reduce the risk of stomatitis. And there is data from the PrecisCa study evaluating fulvestrant with everolimus. So if one chooses to switch the type of endocrine partner, I think fulvestrant plus everolimus would make sense there. In my opinion, we should be utilizing hormonally based approaches until they're exhausted before going to chemotherapy. So regardless of whether a patient has one bone met or liver mets and lung mets, I will try to use a hormonally targeted approach for as long as possible. And that said, if a patient has shorter than 6 months of disease control on a CDK4/6 inhibitor and the disease is behaving very aggressively, I might consider going to chemotherapy first. Those patients are rare, but they do occur. And so I think it's important to keep your eye on the pace of disease, but the majority of patients are able to go on and have PI3 kinase pathway directed therapy. I also would give a plug to enrolling on any of the multiple oral SERD trials that are ongoing, as well as trials that are ongoing to evaluate whether the use of a different CDK4/6 inhibitor, such as abemaciclib, benefits patients whose disease progressed on another CDK4/6 inhibitor. This is not the standard of care practice to do outside of a clinical trial, and the preclinical data suggests CDK4/6 inhibitors shouldn't work after progression on them. However, the clinical trial setting is the place to interrogate questions like that, so I would encourage enrollment in one of those studies as well.